All right, so I am recording this one at home. I have a little bit of time over the weekend here, so I wanted to do another episode, a part two on ECT, because in the last ECT episode, I was just kind of rambling. None of these podcast episodes are prepared in any way. I'm just kind of riffing off some topic I think of as I'm commuting home from work typically or commuting to work. So I have more to say about ECT. I wanted to fill in a few gaps, particularly the parameters of the ECT device itself. Also wanted to just walk through the full, from start to finish, what ECT looks like. So let's start from a consultation actually. So for example, there might be a patient on the unit or in the outpatient setting. They've tried a bunch of medicines for, let's say, unipolar depression, and nothing has worked. They're still not in remission. They're still having severe depression. And so maybe they've even tried TMS or ketamine. So the conversation is brought up about ECT. They have an ECT responsive condition. So the treating psychiatrist makes a referral to an ECT practitioner, an ECT center. So if I were the consultant, the ECT consultant, I would go do a consultation with that patient. And basically, I would be trying to establish that they do have an ECT responsive condition. I'm not going to be spending a bunch of time trying to re-diagnose them, but just making sure that, they're not being referred for PTSD or something like that. And the condition for which they're being referred is communicated well to the patient, et cetera, et cetera. The other thing I'm going to be doing in that consultation is doing a risk stratification, mostly medical risk. So in some places, you will get pre-procedure clearance done by like an internal medicine doctor. You'll have to make another referral to an internal medicine doctor to do pre-procedure clearance or stratification. This is pretty common for surgeries. If a surgeon is doing a case, they'll often ask a internal medicine doctor to do pre-procedure clearance, pre-surgical clearance. So very similar to that. In some programs, because ECT is, not actually a surgical procedure, the anesthesiologist may be okay with the psychiatrist doing that exam. But basically, it's going to involve, taking a look at their medical history, doing a physical exam, doing some basic labs, usually a CBC, CMP, probably TSH, EKG. Some places want even a chest X-ray. Basically, you're focused on cardiopulmonary status and functioning. So whether that's done by the psychiatrist or another internal medicine doctor, that's what you're going to be doing. There are no absolute contraindications to ECT, just relative contraindications, but there might be absolute contraindications for your particular program or your particular anesthesiologist, things that they're just not comfortable doing. This is especially pertinent if you're doing ECT at a freestanding psychiatric hospital. So, at a freestanding psychiatric hospital, generally you're not going to have an ICU there, right? It's just ECT. So your ability to tolerate risk is going to be lower than if you're doing ECT in a full-fledged hospital. The other thing you're going to be doing in that consultation is obtaining informed consent. So let's say, you've established they have an ECT responsive condition, their medical risk appears to be pretty low, they don't have any major cardiopulmonary problems. Then you're going to be telling them about ECT and what it entails and, the risks, benefits, alternatives, and prognosis. So you're going to be getting informed consent there. So those are the main three components of doing an ECT consultation. Once again, you're establishing they have an ECT responsive condition, you're doing a medical risk assessment, and you're obtaining informed consent. Some other things that might happen in that consultation would be cognitive testing, kind of baseline cognitive testing. So in some cases, you might do like a MOCA or MMSE or pick your favorite brief cognitive screening exam. At other places, you might do that at a different time or right before their first procedure, something like that. Kind of depends. But usually we are going to want a baseline cognitive test. Some of that's just to track their cognitive um, functioning over time during the ECT, because one of the side effects of ECT is amnesia, both anterograde and retrograde amnesia that I talked about in the part one. But also, this is a bit of a, you know, legal thing or malpractice risk type of thing too, because if someone down the line a year says that, oh, ECT made my memory way, way worse, you can actually have some more objective data to say whether that is true or not. In general, the research shows, and in my anecdotal experience, if someone really does have an ECT responsive condition and they get better from ECT, their depression gets better, for example, their cognitive scores actually go up after a successful course of ECT. That is true on average. And usually, that's part of my informed consent process, that I'll mention the cognitive side effects, but also say, hey, on average, you'll probably think better if this works out for you. Okay, so you do the ECT consultation, you decide that they're low risk, you get informed consent. So then you schedule the first ECT. On the first ECT, patient's going to show up, they'll get checked in through registration, they'll get assigned a room in a PACU, sort of a peri-anesthesia care unit, pre or post-anesthesia care unit. And the nurse will check them in. They'll probably ask them some questions. The nurse will probably administer like a PHQ-9 or GAD-7 and things like that. The nurse will put in the intravenous line. And then you, as the ECT practitioner, would go see them and do a brief assessment. Just basically, psych review systems, make sure that they're feeling physically well for the procedure. They don't have any new questions beforehand, etc. And then they get wheeled over to the actual ECT suite. And the anesthesiologist is going to, before that, you would hook them up to the EEG recording leads. So for ECT, we usually have a 2-channel EEG, basically one channel recording the overall brain activity of each hemisphere of the brain. You're going to have a cardiac monitor, so you're going to have EKG leads on. And then usually we use the cuff technique. So we're going to put a blood pressure cuff on conventionally the right ankle. I'll talk about that a little bit more later. Then we're going to do a timeout. And that's basically, right patient, right procedure. Basically, this looks like, asking the patient to tell you their name and date of birth and that they're here for ECT. Sometimes you might be more specific and say you're here for bilateral ECT or right unilateral ECT, something like that. And then once the timeout's done, the anesthesiologist will go ahead and proceed to anesthetize the patient. So they're going to go ahead and administer one of the anesthetic agents we talked about in part one. Typically, that's going to be methotrexate. And usually this is dosed somewhere in the range of like 1 to 1.5 milligrams per kilogram. Within, 20, 30 seconds, the patient's going to be asleep. And then they will go ahead and administer the paralytic. Again, this is typically succinylcholine. And then we will establish that they are adequately anesthetized, adequately paralyzed. The anesthesiologist may use a little electrical stimulator to assess the paralysis. You could also check their reflexes, just get a reflex hammer and hit their knee and see if they are areflexic. So once they're anesthetized and paralyzed, the anesthesiologist will, and during this time after they're paralyzed, they're not able to breathe. So they're going to be bag valve masked during this whole time. Typically, we're going to do hyperventilation. So this is usually going to be somewhere in the range of like 30 breaths per minute or more, because hyperventilation can help lower the seizure threshold and therefore make inducing a therapeutic seizure easier. So once we do that for 1 to 2 minutes, then the anesthesiologist will put a a mouth guard in, because during the electrical stimulus delivery, they're going to clench down, and so they can risk biting their lip or their tongue. So you got to put a mouth guard in there. Once the mouth guard is in place, then we will put the electrodes, the stimulus electrodes. So they've already got the recording electrodes, the EEG recording electrodes on their head. Then we will put the stimulus electrodes on. And there's different ways to do this. There are handheld electrodes that you have to hold on like paddles, and you place them where you want to place them and then deliver the stimulus that way. There's also kind of stick-on electrodes and other ways to do the stimulus electrodes. But in the end, they're stimulus electrodes. You then establish that the impedance on the device, which is a measure of resistance, is sufficiently low. And then you can administer this electrical stimulus. It will hopefully induce a seizure, which you can see by movement of their body and also from the EEG recording itself. The seizure typically terminates within a few seconds to a minute. The motor manifestations of the seizure, their actual convulsions, will typically end some period before the EEG manifestations of the seizure end. And then typically after that, they're going to start waking up because the anesthetic and paralytic are going to be wearing off because they're very short acting. So I mentioned the cuff technique. So we put a tourniquet typically on the right ankle to prevent the succinylcholine from perfusing to the right ankle, because the succinylcholine is going to make them paralyzed, and we want to be able to see that they're having a generalized tonic-clonic seizure. So by preventing the succinylcholine from getting to the right ankle, we can see at least their foot moving. That's also helpful just because sometimes the EEG machine, the lead might fall off or something. So having two ways to see that they're having a seizure and that it has ended is really helpful. It's the cup technique can also be helpful because every once in a while you'll have someone that is not fully anesthetized. So they could be paralyzed but not fully anesthetized. And so you could ask them, hey, Bob, can you wiggle your right toes? And if they're still awake and able to wiggle their toes, then they're not deep enough in anesthesia. And it's pretty scary to be paralyzed and not, unconscious. So it can be helpful with that. And then I think from just a kind of safety standpoint, it's good to know that the motor seizure has ended, because if the motor seizure has ended, then most of the time they're going to come out of it. The seizure is going to have ended, and at the very least, they're going to be able to breathe. Their motor activity is not going to be, convulsing. And that's the main thing. So the worst case scenario would be they kind of go into a non-convulsive status epilepticus, where they're altered, but they're still able to kind of carry on their basic functions of breathing and things like that. So I think the cup technique is important for that reason. And then you deflate the cuff after the seizure is over. A couple of other things I wanted to mention in regards to the procedure itself, the parameters of the machine and how you set it. There's different dosing, there's different parameters, and I'll talk about that in a part 3. But that gives an overview of just the detailed blow by blow of the procedure itself. Once they're awake and talking, they'll, you take off all the leads, and then they get wheeled back over to the PACU to recover, because they're going to be a little bit groggy, and we want to just make sure their vitals are fine for a while and stable before the discharge, and get the IV removed and all of that. All right, so I will have to continue this in a part 3, I guess.